Hi everyone, good morning, good afternoon. My name is Manny Shikman. I am the Vice President of Business Development here at TytoCare. And in this session, we would like to talk a little bit about inequalities of access to healthcare services. As you know, according to WHO, half of the world's population lacks access to essential healthcare services. So I would like to introduce Jose Alvaro, the CEO of the Little Prince Hospital Complex in Brazil, and David Vitaltech in Chile. Both are adopters of TytoCare technology, and both will talk a little bit about how their organizations address the inequality challenges in their respective countries. So we'll start with Jose Alvaro. Please go ahead.
Hello, everyone. Hello, Manny. Thank you for the opportunity. Hello, David, also. Good morning, everyone. Good afternoon, everyone. Even good night, everyone. Well, the Little Prince Complex we are a very old organization. We were established in 101 years ago, and since then we have very strong points in time related to our history. Our first hospital got ready in 1930, and after that, in 1972, we have a new building, and we implement the number of beds and all of our in order to Well, 100 years old, I have to tell you that we have the strength and the joy of the children that we exist. Then, as I said, this is in order what we have done since today. You can see our main building of the hospital. Then,
I believe the slides are not moving, so maybe if you exit the presentation mode, like we had with Ophir, and just do it in a regular mode, because for some reason the slides are not moving.
Okay. So in 2003, we have started our college. In 2006, we made the inauguration of our research institute with the support of Pele. We are the only organization in the world that could use the name of Pele. After that, in 2008, we just inaugurated our genomic lab and biobank. And in this year, 2021, we will be carbon neutral. Let's say that we are one of the first hospitals in the world to neutralize greenhouse gases. Well, in numbers, we are almost 3,000 employees, almost 400 physicians. We are 378 beds hospitals, from those 68 in ICUs. We have had in 2019 almost 300,000 outpatients, 22,000 admissions, 20,000 surgeries, 274 transplants, considering all, we do them all, hearts, liver, kidneys, bone marrow. We, in the research institute, we have 16 senior researchers, ongoing 55 projects in 7 research lines, and we have in the college 1,006, almost 1,600 students under qualification. Well, where we are We are in South Brazil. Brazil is a huge country, and we are in the south area. We have a huge challenge because we serve mainly the public health system. We have around 60 to 65% of our patients coming from the public health system. And that means just 22% of our revenue. Then we have a huge deficit considering the assistance of the public health. And because of that, we are very good in fundraising. Well, the health scenario in Brazil is very difficult at the moment. We are in a deep economical crisis in the last years. So around 4 million people lost their private health insurance plans. And at the same time, the philanthropic hospitals in Brazil are responsible for 60% of the complex hospitalizations to the health system, the public health system. And considering pediatrics, between 2009 and 2019, 16,000 beds were closed in the country. That means 42 Little Prince Hospital equivalency. Well, we have to consider that Brazil is a continental country with profound and historical inequality, where the development of hospital performance and access to high-quality healthcare goes directly to technology shortening distances. With that, I bring to you that one research done last year, in the beginning of 2020, almost all of our doctors, 65% of the doctors in Brazil, communicate with patients through WhatsApp. That's a huge challenge because that means that our market is not ready, is not mature to technology with safety. Our experience in telehealth started in 2016. It's a kind of medicine between ICUs. Here in Brazil, in our neonatal and also in our cardiac ICU, and you can see in the slide the Children's National Washington Command Center, where we exchange and we talk about our patients. With that, you can see a robot that we use now. We are doing that in the last 5 years. And the challenge is to articulate a network inter ICUs and NICUs, focusing in babies with complex pathologies and establishing of standard protocols to face potential increase of COVID cases in children. Well, in 2017, we have the joy of discovering Tyto. It was fantastic to see the existence of that device. Then, we started something very important. In 2018, in the beginning of the year, we have met the Tyto people in the CES standard that TytoCare have made in Las Vegas. I get there with our director responsible for the technical things here in the hospital, a physician. Then, as soon as we get in contact, we went through our regulatory nightmare here in Brazil. We have a tradition in bureaucratic things. Then after that, we begin to run all that. In last year, 2020, we start the research here in the hospital, and also in a very famous hospital also in Brazil, Sabará in São Paulo, involving 700 patients. We started last year also a movement and a pilot program in the Cacané local native Indian village that we have close to us here in Curitiba, but we interrupt that due to COVID lockdown and restrictions. We also start a pilot program here in Curitiba and in a city called Paranaguá in the shore of Paraná. In last year, we also launched TytoCare, a company that we have made together with the Sabará Hospital, and we have had our first client, Care Plus, a company who is part of the Bupa Group. TytoCare put together two of the main brands of pediatric care in Brazil, Little Prince and Sabará, and we are the exclusive distributor of the TytoCare here in Brazil. Our big challenges will be to Trinda, to open the Brazilian telehealth market for private healthcare insurers and hospitals through the device, providing safety in effectiveness to the user, patient, and every health professional. Considering Little Prince Hospital and Trinda, the main goals will be to consolidate and improve the Cacané native village as a pilot program, and to just after that to replicate the program for another two local native Indian villages in Paraná and one native Indian village in the Amazon region. Then also to consolidate and improve the health center pilot program for children in local cities as Curitiba and Paranaguá, related to the public health system in Brazil. So then the future highlights that we have in our today's life, it will be always clinical performance, technology and telehealth, and for that Tyto is a very, very important step. Genomic and precision medicine, bioethics, equity, sustainability, and ESG, environmental, social, and governance. We do trust that device that Tyto has brought to the world, and we do believe also that that will make a huge difference to the health assistance and to the access of a good quality medicine in Brazil through that device. Thank you.
Thank you, Jose Alvaro. Again, amazing work that you and the hospital are doing, bringing healthcare to what sounds like very rural, remote locations throughout Brazil. And with that, I would like to pass the microphone to David to talk a little bit about his work in Chile. Go ahead, David.
Okay, morning, good night, everyone. Thanks for joining us. The idea of this conversation is to talk about how are we breaking down the barriers to care. So we are not as SEV in a hospital. We are more like innovators in terms of using technology to go and to move forward into developing the kind of care that everyone is expecting to receive. So a little bit of our highlights in terms of where we are now. Obviously, we're in Chile, right? Some of you know Chile because of the wines, others for the landscapes, and there you have a Chile as well. But in terms of population, it's going to be very interesting for us to let you know that we are only a 19 million population country. Average PBI right now, it's going to be like 14,000 or barely like that. But we are a very strange country in terms of the structure of it. We are like a knife, as you see there, as a chili, and we are based in Santiago, which 60% of the total population more or less lives in this region, and obviously 60% of the health capacity is in Santiago. So there's lots and millions of people which are now underserved in terms of the capacity, and almost 10% of the entire country lives in cities or in rural places where they don't have nurses, physicians, doctors, nor a hospital. So saying that, we have bad news because the system is now old. Unfortunately, the public sector, which is the one that serves 75% of the country, and the private ones only for 25, are absolutely distance between one and the other in terms of the service. So the last survey made by the Minister of Health in Chile says that 82% of the population considers the public system, the health system, as a non-effective one. So just for an idea, and we have 2.2 beds per 1,000 inhabitants, which the OCDE average is 4.9. In Germany, you have like 10 right now. In Japan, you have 14. So we have a long distance right now into become a first world country in terms of the service. You see here some images, okay? And those are the waiting times that all the people have to wait outside of the hospitals or the little rural hospitals, and they wait around 7 hours in average to receive 1 or 2 services. But the problem is that around 2 o'clock, they close because there's no more capacity. So people have to come after the day after that to again wait. And a very unfortunate situation that we have now is that in the bottom picture, you have a construction of a hospital, and just on average in Chile, it lasts 15 years, more or less, to build it. But the problem is that we are lacking the kind on the type of hospitals needed. So we are gonna be in year 2035, more or less, with the construction of these hospitals. So that becomes a 20 years late constructions for the real necessity. Okay, so there's more bad news, and this is where we come from. Unfortunately, COVID brought the health system to its knees in Chile, in Brazil, in New York, or every other country in the world. So what happens with that, obviously, year and a half ago, year and 2 months ago, it happens that the Ministry of Health in Chile and every country in the world said, stay home, stay safe, do not move, right? So we don't need more contagious going around in the streets. But when we say this, some of the population could stay home, but some others can't. They are dying because of that. So saying that staying home is not their best option, we focused on the elderly and the chronic patients. 2.6 million people are plus 65 years old in Chile, and those barely 80%, most of them 80% are chronic patients. So they cannot stay home. Okay, why? Because they're going to die without the treatments. So we decided to do something and help those in need now. How? Moving the health services from the hospitals to a home care service with quality, right? Partnering with doctors, municipalities, and private companies, delivering a high quality service when they need it and wherever they need it, not just in Santiago, in the rural, in the mountains, in the rivers. So then we build it and started. What we say in Spanish is contagiemos salud. It's more or less in English like spread health. Let's, ironically speaking, let's not be staying home, move the health systems to their homes and deliver what they need most. So what we become, it's a social movement that delivers health solutions to thousands, maybe millions of chronic and elderly patients, and clubbing primary care centers, which are the images that I showed you before, and the waiting lists obviously for the underserved population. What are the waiting lists? In Chile, we have the public sector, which is not, it's not properly deployed. So people are waiting more or less 600 days for a specific consultation with a physician. So the problem with the elderly and the chronic patients was that they cannot wait. They need to have based monthly treatment for that. And the problem with COVID staying home is that, one, they cannot receive that treatment. And second, is that these waiting lists are increasing in rates of 25% in the last 6 months of the year. So we don't have now only almost 2 million people in the waiting list. Maybe now we have 2.5 million. So what happened is that they need an urgent service. So what we did is that in the left side of the screen, we partnered with municipalities, with the Ministry of Health, and they provide us their doctors, their nurses, their equipments, so we can assure in Contagiemos Salud the legal and operational acceptance of the patients. Secondly, we use technology. We use, obviously, based on innovation, so high-end technology, and partnered with companies that deliver product and services behind us. So in every home care visit that we do, after that, there comes like a truck or a van that delivers products that these people, which most of them also are vulnerable socially, right? They don't have now, because of the unemployment, they don't have jobs. So we are delivering food, we are delivering medicine, we are delivering any kind of help that we could do. And secondly, and the most important, is that patients don't have to be running for 7 hours waiting time. They are waiting us home. So they are in their comfort or of their place, being with their families, with their care suppliers, and without any risks. So here you have some images that shows that here we have the Santiago municipality, which is obviously the biggest and the most important one of the capital of the country. We have another rural municipality, which is San Bernardo, and we have a charity fund, which is Hogar de Cristo, which is more or less if not the first, the third most important NGO in Chile. So here we are working the plan to visit and to go in to serve those in need. Here you have the results, some images of how we deploy different kind of services with nurses, with different doctors, obviously online through TytoCare in this case. So we are serving elderly, and then you have in the right, we have also kids. So then you can see here the poverty of the places that we are visiting, and the kind of situations that we are focusing. And here I would like to show you a little video that is more or less the resume of what we are delivering. So I hope you enjoy. I'm going to be talking about it because of the audio, okay? This is the Santiago municipality. We started with them in December, a pilot program to help 6,000 elderly population, which could not obviously move. You have home patients that are chronic. You have the ones that are only elderly, but in good conditions. And we deployed through this device and this platform a kind of service, obviously, which is free for them, because we are using the partnerships that we have done, and we are giving them the care and the special care of their needs. And then the public sectors goes and bring them the medicine, all kind of things that they need. This is the mayor of Santiago, Felipe Alessandri, which is the one that trusts us first in terms of moving this program into their population. We started with 6,000, as I said, and now we are moving into 18,000 elderly from 65 up. So the technology that we are using allows us to do all the exams, but also the benefit of being cost-effective solution is helping them to to bring new programs and new solutions. Like, for example, we are saving some data that their doctors are using afterwards in their care centers. Okay, this is me talking a little bit, which is embarrassing, but later on, I will jump here to the final of the video, which you can see that we are obviously helping people who are in real need, the one that obviously is in the bed, and obviously you have those that only need a monthly service.
Then, David, let's pause here. Thank you again very much for the explanation and the amazing work that you're doing in Chile. I do want to allow people to ask a few questions here before we conclude the session in a few minutes. So maybe one question to Jose Alvaro from the Q&A session. And again, for the questions we won't have time to get to, we can answer offline, certainly. But Jose Alvaro, one of the questions is, how were you able to, or rather, what challenges did you face to convincing patients and providers to adopt telemedicine in the hospital?
I would say that the main difficulty that we have here are related to the old-fashioned way of doing things, mainly with doctors, with physicians. We here in Brazil, as I have shown to you, many of our doctors are related to do telemedicine through the telephone, to the cell phone, and through WhatsApp. To change that into something that could bring more accuracy, to bring more trust and security to what must be a telehealth assistant would be one of our biggest challenges.
Got it. And so maybe one last question to both of you around work with insurance. I know there was a question also in the Q&A feed, how important it is, and if you are working with insurance companies. So Jose Alvaro, you mentioned Bupa in your presentation, which is obviously a major health insurance in the country. David, you're working with some of the public entities. So can you talk, both of you, a little bit about working with insurance, and then we'll allow people to go to their breaks.
David, go ahead.
You're on mute, David.
Now, these insurance companies being a partner from the public sector, it's more or less like a second stage, because the public sector itself, it's insurance. It's own services. So in this case, we are partnering with companies and health suppliers more than insurance, because the system itself is insured.
Okay, in our side, I have to remember something. In Brazil, telehealth at the moment, there is no regulation for it. We have at the moment a huge discussion in Congress to do that, but it's not regulated yet. Our relation with the providers, mainly big companies that are in Brazil providing private health insurance plans, we're being very, very well received. And we do believe that during this year of 2021, we will start doing very big sales of Tyto, not just the device, but the Tyto device and the service related to these companies. Considering public health system, we will have to, and we're doing that, we will have to prove the efficiency, the cost efficiency, and also the benefit of the device in the assistance. And we are doing that. To be able to show the benefits of the system and the cost of the system to the public health system. And we are doing that, and we do believe that during this year, we will be accelerating all this process.
Excellent. Okay, so this will be our last question. We'll collect the Q&A questions and address them in the future offline. Again, thank you both for excellent presentations and the work you're doing in your respective countries. So we're now going to have a 10-minute break. So for all of the attendees, please navigate back to the Sessions tab and join our next round of sessions for panel discussions. You have a choice of virtual primary and urgent care, which will include Novant and Optum United healthcare groups, as well as Spectrum and Sanford, or you have a session on a remote patient monitoring with University of Miami, Ochsner, Prisma, and Dispatch Health. Again, thank you all for attending the session.
Thank you very much.
Thank you, Manny. Thank you all for visiting.
Thank you.
Have a great day.